We usually make a joke during trainings to say that if the child is in a breech position and the feet come out of the mom first, you can literally start casting as the feet are coming out, the nurse taking the child to finish the delivery. So that is just to say that treatment can commence as soon as possible. My name is Victoria Kimathi. I'm a physiotherapist by profession and I work for an organization called Clubfoot Care for Kenya, stroke Hope Walks Kenya. The best health professional to see when one has clubfoot is a rehabilitation clinician, that is a physiotherapist, occupational therapist, or an orthopedic technologist. Apart from that, one can also see an orthopedic surgeon, and I mention these because they are the best equipped people for dealing with clubfoot. So one can go to any health facility, but these would be the best people to see. Clubfoot is a condition a child is born with in which the feet are turned inwards and downwards. So this is just a plastic model. You can see that the foot is turned inwards and downwards, making it very hard for somebody in the future to walk. So in a nutshell, that is what clubfoot is. Clubfoot occurs in about 2,000 children annually in Kenya. That is 1 in 800 children who are born. There is a study being done by the Ministry of Health that is showing clubfoot is the most common congenital deformity. That means it's even more common than conditions such as spina bifida, cleft lip and palate where there is an opening in the lips, and many others. Globally, clubfoot occurs in 1 in 1,000 live births. So it's also a very common, one of the most common congenital conditions globally. Clubfoot occurs in the first and second trimester when basically the bones are developing in the child. By about the 24th week of pregnancy, that's around the 6th month, if a mom does a 3D ultrasound, clubfoot can actually be detected and diagnosed. Clubfoot does have a hereditary link to it, or genetic link. It's been seen in 3 to 10% of people who have clubfoot in their family can actually pass it on to their children. So it's not very common. It is possible for somebody with clubfoot to bear children without clubfoot, but yes, it does have a hereditary link. The challenging thing with clubfoot is that we do not know its cause. So because of that, we are not able to prevent clubfoot. But what we now know is that it can be treated with a method that has a 90% and above success rate. The signs of clubfoot are basically very visual. That's the good thing about clubfoot. So you can see the foot is turned inwards and downwards. When you try to move the foot, you can feel some resistance. So that is what we call a true clubfoot or an idiopathic clubfoot. There are some feet that appear to be in this clubfoot-like position, but once you move them, they can easily move. The feet are flexible, the child even plays about and is able to get out of the clubfoot-like position. Globally, it's been noted that clubfoot is more prevalent in boys. The cause is unknown, but for every girl that is affected, 2 boys are affected. So it's twice as common in boys than in girls. We usually make a joke during trainings to say that if the child is in a breech position and the feet come out of the mom first, you can literally start casting as the feet are coming out, the nurse taking the child to finish the delivery. So that is just to say that treatment can commence as soon as possible. If the child has other conditions that require immediate medical attention, Of course, we would opt that the conditions are first treated and then clubfoot is treated later. Clubfoot is treated through a technique or method known as the Ponseti method. In the Ponseti method, there are two main phases of treatment. There is the corrective phase and then the maintenance phase. In the corrective phase, we have weekly castings and manipulation, a method, a small surgical procedure known as a tenotomy, that is the surgical release of the Achilles tendon that's attaches over here at the heel. In the maintenance phase, we have bracing. In Kenya, we use these braces known as the Steenbeek foot abduction braces. So in the casting phase, the clinicians follow specific methods of manipulation, that is moving the feet, in which the foot in the beginning is placed in the bones of the foot are aligned in a specific way. A cast is applied, or that is plaster or POP, all the way up to the groin. The child comes back after 1 week. The cast is removed. The bones of the feet are manipulated again. That is moved in a special way. The child comes again after the plaster is applied. It's removed like that, until now the position we desire is achieved, which is this one, where the feet are facing outwards as opposed to facing inwards. But because there is still tightness in this tendon, a procedure known as the tenotomy procedure is done, which is a release of the Achilles tendon that attaches on the heel. After the tendon is released, the foot can go up. The foot is casted in this position. The cast is maintained for 3 weeks. After that, the child comes back to the clinic, the tenotomy cast is removed, and now we apply the braces. The braces, as you can see, are turned outwards and actually allow the foot to go up a bit, or what we call dorsiflexion in medical terminology. These are used to maintain the correction that was achieved in the casting and tenotomy or correction phase of treatment. The braces are worn for the first 3 months for 23 hours, allowing only 1 hour for diaper changes and for the patient to be bathed and so forth. After 3 months, the child wears the braces at night only and during nap times until the age of 5. So this is just an example of one size of a shoe brace. We have other sizes of shoe braces, of these braces, that are now changed as the child is growing and coming for clinic visits. So we actually stay with the child up to the age of 5, when now they should be discharged. Yeah, I'd also like to add that in our clinics, we offer psychosocial support through what we call a parent advisor. So the parent advisor's role in the clinic is to be with the family, explain to them the treatment process in the beginning, especially, so that their anxiety reduces, follow up missed appointments, and just be a support system for the child and the family. Link them up with the local churches, yes, and ensure that they do not drop out. Because it's a 5-year treatment plan, we usually have a lot of dropouts. People move as they get jobs, they decide now, because the feet are looking good, my child is walking, I am free now, I don't need to put the braces. But the reality is that the clubfoot can come back. So it's very important for them to be able to be followed up now through the parent advisor. The beauty with the Ponseti method is that research has shown that it has very little side effects, as opposed to what we used to do in the past, surgery. So with surgery, research shows that it actually brings a lot of pain. There's a very high chance of relapse of the clubfoot coming back, and also inability to wear shoes of the person's choice. So as Clubfoot Care for Kenya, CCK, together with Hope Walks, we actually foot the bill for the patient in Kenya and even in the other Hope Walks countries. So we partner with organizations, or that is hospitals. Currently we have 23 to give clubfoot treatment to the population at a free cost, so no charge at all. But what we realized after we did some cost analysis is that about 40,000 Kenyan shillings would be needed for treatment of clubfoot if one was to pay. Treatment for adults is challenging. If they're a young adult, that is around 18 to 20, they still can get treated. What they would have is probably some few weeks of castings and then a surgery. But with the older adults, because of they've probably been through surgery before and it didn't work out, or anything, so they are usually not open for surgery because of the long recovery time. They usually opt not to have the surgery, and also the surgery is usually associated with a lot of pain and a high chance of the foot relapsing. So most adults with clubfoot opt not to have the surgery, but they can have it. The shoes for adults look very different from this. They are what we call surgical boots. So they have a good allowance of the sole, depending on the person's height, of course, and they are able to give firm support around the ankle. Yeah, but those are worn, they don't have a bar between, they're just worn in both shoes. Many adults, older adults with clubfoot, opt to just use their own kind of shoes because some don't like the appearance of the surgical boots and also the comfort. I know of adults less than 18 years of age who've been treated. Unfortunately, I don't know of anybody above 18 who's successfully been treated for clubfoot. In Kenya, the biggest challenge with accessibility of clubfoot services is actually the lack of skilled clinicians. Government has gone far with providing health facilities in many locations in Kenya, even in rural locations. But you find that in a lot of these health facilities, we don't have people who are skilled in the management of clubfoot. So I would say for Kenya, that is the biggest factor for accessibility of clubfoot services. The other factor is transport. In the places now where there are skilled clinicians for treating clubfoot, patients don't have transport to be able to get to the clinic, and probably even money to buy the plaster and all the other things that they are charged when they are at the non-CCK clinics. Congenital conditions are covered by NHIF in the sense that when there is surgery, NHIF can actually help to or foot the whole bill for the surgery. But if the child needs more of casting, like in clubfoot or other devices that help the child to achieve walking and all the other milestones, then those are somehow seen to be cosmetics. So most insurances actually do not cover them. Yeah, so it usually is a costs specifically, it's an out-of-pocket cost for most patients. Now the psychosocial aspect. So in Kenya, clubfoot, just like with many other conditions, is associated with witchcraft, a bad omen, a curse. So we find a lot of parents actually opt to hide their children. Therefore, they come for treatment later. And as we've already talked about, the benefits of starting clubfoot treatment early. So what I would like to urge the population is to affirm the fact that clubfoot is not a curse. It's not caused by somebody looking at you badly or a bad omen. It is a congenital condition that we thank God can be treated and addressed early. The child can actually achieve all their milestones and be a fully functional member of the society. If you know anybody who has features of clubfoot, kindly feel free to refer them to our facilities as Clubfoot Care for Kenya. We are very ready to help them in any way that we can, that we know. If you know of children who have even other congenital conditions, feel free to refer them also to our various clinics. As Clubfoot Care for Kenya, we rely on donations from abroad. We have been working to also look for donations locally. So if you know if you have an organization or know any organization that we can partner with to give children these services, we implore you to reach out to us and we can partner to give this service to our children. These are our children, they are our future. We have to brighten up their future. Yeah.